Hi, everyone. Welcome to the AlloGraft Ring Refresher webinar. My name is Victoria Mickelson, and I am the Biomaterials Marketing Manager at Straumann. So I have with me today is Dr. Bob or Robert Miller. So Dr. Miller began his practice of periodontics and implant dentistry in 1986. He has 3 practices in Florida, and he was one of the original AlloGraft Ring trainers. So he will be doing the webinar today. Just some logistical things. All of the participants are muted, so we cannot hear you. So don't worry about talking too loud or chewing. We cannot hear you. There is a question box on the control panel. So if you do have a question, please enter the question into the question box, and we will address all of the questions at the end of the session. All right, so we're going to get started. The webinar is recorded and it will be distributed following the webinar. So I'm going to hand it over to Dr. Miller.
Okay, well, I want to thank everybody for taking their
Dr.
time out
Miller, we
today.
cannot hear you.
You cannot hear me. You can't hear me. Why not? Sharing. Do I have to hit sharing? Can you hear me now?
Yes. Yep,
Okay.
you're good.
I'm good. Are you sure?
Positive.
Okay. Well, welcome everybody. I want to thank everybody for making the effort here today. I want to thank the people at Straumann. I want to thank Victoria for making this happen. Obviously, Donna too. Unfortunately, here Donna's under the weather. And most off, I want to thank. This is what you're seeing right now is the gang. On the left, you see Dr. Giesenhagen. He's the originator. I'm sure most of you guys remember him. That's Dr. Randy Korn, my partner, Frank, Danny, that's Donna, and myself and I'm on the right. Now, the title of this presentation is, well, we're calling it an allograft ring refresher course, which I think is actually very appropriate. And I actually agree that actually Victoria and I were talking about it earlier, and it is a little bit long overdue. Now, the title that they gave me to work with was How to Maximize the Efficiency in Your Practice. And to some kind of strange way, I think that's kind of presumptive. In other words, I don't know if I really know everybody's practice. But what I really want to, I think, is an appropriate way of looking at this webinar is actually where I'm at today. In other words, now it's been close to 3 years that I've taken the allograft ring course, and about 2 years and 8 months I've been placing the allograft ring, and what I consider in a very predictable fashion. Okay, it's become a very much a mainstay in my practice, and that's what I'm going to try to impart to you today. So essentially, I'm going to sort of give you a state of where I'm at today with the allograft ring. And what I'm going to do is I'm going to break this up into a couple of small parts. First off, we're going to talk a little bit about best practices. In other words, how you can actually use the allograft ring and make it a very predictable part of your practice. Okay. In other words, I'm going to hopefully show you how that you can use it and kind of avoid some of the pitfalls that you kind of may fall into. Second, we're going to talk about case selection, and I actually think that that's probably the most important thing with respect to just about any procedures that we do. It's all about case selection. So I'm going to review some of the determinants that we use to decide whether or not an allograft ring is appropriate. Then what I'm going to do is I'm going to talk a little bit about complications and how you can overcome some of these adverse events. And I'm going to show you a couple of my own personal complications, how I sort of fell into that, and how I sort of rectified it. Okay, that's a big thing that a lot of people ask me about as well. And then lastly, I'm going to talk about promoting the bone ring. And I still believe that the allograft ring comes with a huge wow factor. Okay, not just from the referring doctors, but also from patients. And I still believe that if you give a patient the option of having the GBR procedure as well as implant placement done in the same procedure, they're going to pick that 10 out of 10 times. There's very few people who are going to say, listen, I'd rather do that and have two different surgeries. So I really do believe that promoting the bone ring to your referring dentist is and your patients is paramount to it definitely makes you look like the latest and greatest. So with that, as Victoria said, I want you guys to hold off on some questions, type them in, and we're going to have plenty of time at the end of the webinar to address all of your questions. Now, to start off, what I want to do is I want to show a case that sort of signifies where I'm at today with the allograft ring and what I've done and how I've grown with it. And this is a perfect example of a patient. This is about a 70, 74-year-old gentleman, relatively healthy guy, and just taking some medicine for some hypertension, but really no real medical complications. The guy works full time. He's a very ambitious guy, has very little time, and it's one of those things where the allograft ring, when I presented it to him, was something, yeah, sign me up. So the story is that basically here's the radiograph. It's tooth number 9. You can see that he has some significant bone loss around tooth number 9. No longer is that restorable. It's about a class 3 mobility. He has a generalized, what I would call a chronic, slight to moderate chronic periodontitis, which was controlled relatively easily with periodontal therapy. But tooth number 9 had to be replaced. So when I actually came to him and I said, listen, here's what we can do for you. We can consider a dental implant here, and we can do it as a one-stage procedure. He was all in. So here's how we handled the case. Tooth number 9 was extracted, as you might guess, relatively easily. We took the tooth out. We reflected a full thickness flap. You can see the size of the osseous defect. And typically, these are situations where you might consider doing doing this in a two-stage approach. But with the allograft ring, we had the option of doing this as a simultaneous procedure. What I decided to do with this case is that we wound up using, I was going to try for a little bit of GTR, guided tissue regeneration as well, trying to rectify some of the defects on the mesial and distal aspects of the adjacent teeth. So we used a combination of hand instrumentation and ultrasonics to prepare the adjacent teeth. I used Pref Gel, which is a chelating agent, EDTA, on the root surface, and then I start preparing my ring bed. Okay, I went in with my 2.2 twist drill, then we went in with our Trefine, and went in after with our planator to flatten the ring bed preparation. On the right, you can see the allograft ring being held in position with the direction indicator. And believe it or not, that's a pretty snug fit there between the ring bed preparation and my apical native bone holding the allograft ring and direction indicator in place. That's a pretty snug fit. So the next step here is to actually cut the allograft ring. And what I did here is I actually left it a little bit high because I'm kind of hoping for some regeneration along the adjacent teeth. We cut it using our saw, and then we finished our osteotomy with the 2.8 millimeter twist drill. And the implant I used here was a narrow connection bone level tapered implant with a 6 millimeter diameter allograft ring. Here's the direction indicator on the left, and then I'm placing my implant in the center photo, and you can see my relative implant placement. Hopefully that's in a restoratively driven fashion. So and now I'm also using the Jason membrane. Now, the Jason membrane is a porcine pericardium membrane. And the reason why, there's a couple of reasons why I like using it. One is it's a very, very easily adaptable membrane, doesn't have a huge memory, so when you put it in place, it really stays very nice. And the other reason, which I feel very strongly about it, is its resorption time. It basically turns over in about 4 to 6 months, which from a time perspective works out very, very well in concert with the allograft ring because I'm not actually exposing or loading my implants for 5 to 6 months. This isn't happens not to be Cerebone, but I'm using also Cerebone now as for my Xenograft. And the reason why I like that product is its hydrophilicity. Really, really, it when you place it, it really stays very, very nicely. It packs very, very nicely. So I've been using a lot of Cerebone as well with my allograft rings. Two good products that have just recently come to market. So I'm securing my membranes now using the fixation cap. And you can see in the center picture here, you can see where I use my fixation cap and I've actually secured the membrane in place so I don't necessarily have to use tacks. And then I also, one of the things that Dr. Giesenhagen has taught me is never, never, never skip the horizontal mattress suture because that really, really ties things together nicely, creates a nice tension-free flap. Here's our radiograph. You can see the fixation cap in position. You can see just how much we grafted between the allograft ring and the freeze-dried bone. Next step is we hurry up and wait. And, a lot of these patients are chomping at the bit. This one actually dragged his feet a little bit because it was difficult to get him into the office, and it turned out to be about 8 months. And you can see our stage 2 implant recovery. And this is a picture with the healing abutment in place. But this is really what I consider the money shot, which is a CT scan. And I think most of us looking at that buccal plate would be very, very, very happy to see something like that. And that to me speaks volumes. And we have a nice osseointegrated implant with a very, very thick buccal plate. And that to me gives me an awful lot of confidence to go to finalization. And this is about 3-4 days after the final was placed. And I'm hoping in the next few months that we might even wind up getting back that papilla between the two central incisors. He was extremely, extremely happy. Here's a shot of the final restoration, and you can see just how much bone. If you look at the mesial and distal aspects of the right central incisor, they're almost level at this point. Here's our before picture. Here's our after picture. And here is the radiographs of the before and after. And again, I think we were able to accomplish a small amount of GTR as well as accomplish having a really nicely osseo integrated implant at this point. Okay. Now, what I want to review is some of the indications. And what I've always recommended at the courses is that when you actually go ahead and start doing the allograft ring, what I suggest doing is using your first few cases as sort of a test drive, so to speak. In other words, don't necessarily throw this technique into a procedure that probably you're not going to be successful doing anything else, because that's chances are you're setting yourself up for disappointment. But there's a number of indications that I think are very, very predictable. One of them being a four-wall defect. Okay, that's where you have your mesial distal buccal and palatal walls. And these are basically large extraction sockets that typically you'd be doing in 2 stages, but sometimes the allograft ring can help you to do this as a one-stage approach. The 4-wall defects are extremely, extremely predictable. 3-wall defects are usually my typical cases, and the 3-wall defect is usually a mesial distal and lingual or palatal wall, and either you're trying to regenerate that buccal plate or create some sort of root eminence with your allograft ring. 2-wall defects also very, very common for me. I'm using those are situations where you'd basically most likely just have your mesial and distal walls, and your buccal and palatal walls are usually you're trying to regenerate. I'm using this procedure an awful lot as because it's sort of taken the place of maybe some of the ridge splitting procedures that I've done in the past, where we're trying to place implants simultaneously. So this is a very predictable approach. One wall defect's a little more rare, but sometimes you get situations where you're missing your buccal plates, you're missing your lingual, or you're missing your mesial and distal plates. But zero wall, which I consider um, the sinus indication, for instance, I firmly believe is a very predictable use for the allograft ring. As a matter of fact, I think it's something that everybody should be doing. It's I grant you that um, that it appears a little bit ominous the first time you try it, maybe the first 2, 3 times you try it. But let's go over one of those cases, because I really do believe that the sinus indication is something that people should be doing far more often than they do. Here we have a situation where we have an upper right 3-unit bridge that's failing. The mesial and distal abutments are definitely decayed, periapical pathology. We removed the bridge, not very difficult extractions. And at this point, what we're going to do is we're going to open up the area. And typically I use either rotary instruments or my piezo surgery, or a combination of the two, to expose the Schneiderian membrane. And then what we're going to do is we're going to place our allograft ring. And there's a couple of little tips that I think are very much helpful. And one of them is to pack some bone mesial distally and on the medial wall prior to placing your allograft ring. Two is when you're actually doing these allograft rings, there's a couple of things that you got to kind of keep in your mind's eye. One is you have to have a nice size window, no question about it. And two is the trickiest part about when you're doing this technique is stabilizing the allograft ring within the sinus. And what I'm usually using is there's an instrument that is a forceps that is included in your ring kit that does a pretty good job of stabilizing it. But it also can be stabilized using college pliers to put some downward pressure and hold the ring in place as you're placing the implant through the floor of the osteotomy on the floor of the sinus. So you're stabilizing it with either college pliers or the forceps that comes with it. And generally, with the bone level tapered implant, because of its tapered nature, it actually finds its way into the donut hole of your allograft ring pretty readily. Now, I've also used my remaining BL implants for this as well, because it's sort of a smooth floor to the implant, the apical end of the implant. And I thought to myself, oh, maybe that's a good idea to have the old BL implants. But I really haven't noticed that big of a difference if you're reflecting your Schneiderian membrane thoroughly. Okay. The other tip that I sort of throw out there, which I think is another small tidbit, is you don't need to use 8 of the 10 millimeters of the allograft ring to stabilize your ring in the sinus. You can cut it down to 5 or 6 millimeters and easily stabilize your ring pretty nicely. Now, sometimes the floor of the sinus is actually curved. So sometimes you either A, have to reshape the one end of the allograft ring so it'll sit passively on the floor of the sinus, or if the floor is wide enough, sometimes you can actually plane it using your using your piezo surgery unit to make it a little bit flatter so your ring can sit passively on the floor of the sinus. Those are a couple of little things that I kind of keep in my mind's eye when I'm actually doing these sinus procedures. I'm using a combination of Xeno and allograft, and then we use a membrane flex. You can either use any membrane here in terms of cross-linked or non-cross-linked, and as long as you have something on the buccal aspect of your uh, um, window into the sinus. Again, we always use horizontal mattress sutures, some interrupted sutures. I'm also, this is a 1 week post-op. This is about 6 months. We go ahead, back in, re-enter the area. You can see that we got an ISQ value of 73 for the distal implant, which is really, really good for a 100% grafted sinus just after 6 months. So we have a lot of confidence that this implant is osseointegrated and that we can go to finalization. And this is the final radiograph of the implants and restorations in place. So again, I think the sinus indication is an enormous advantage with your allograft ring. Gives you enormous advantages. Now, let's go. I just want to review real quickly to the decision tree. And I really, really believe that this is at the heart of case selection when it comes to predictability and the allograft bone ring. So when we talk about bone defect classification, I found the old Bennick and Hammerly bone defect classification, which classifies these defects in terms of 0 to 5. 0 meaning there's really no defect. And in those situations, oftentimes what we're doing is removing bone because we need our implants about 3 millimeters apical to the adjacent CEJs. Class 1 defect is usually maybe a small moat-like defect. Class 2s, a little bit bigger, dehiscence type lesions. But all 3 of these defects are call for immediate implant placement, okay, with or without a small particulate bone graft. Okay, defects classified as either 3, 4, or 5. Well, they're a little bit larger. Okay, maybe class 3 defect, a larger dehiscence type lesion, but you can still possibly place the implant within the confines of the bony envelope. So some of these situations you're doing a simultaneous placement. This one I did simultaneously. But most of the class 3, 4, and 5 type of defects, those are defects that in the past, what I would do is I just basically do it as a 2-stage procedure. Okay, no question about it, because I was afraid of either implant failure or not placing the implant in a restoratively driven fashion. But as I said earlier, with the allograft ring, now I'm sort of rethinking when I'm going to be doing implants simultaneously. So in these 3, 4, and 5 type defects, I'm considering doing my placing my implants simultaneously with my GBR procedure. Now, other determinants that have to be taken into consideration is, can you place this in a restoratively driven fashion? And today, there's no reason that you should be placing implants in situations, well, that's where the bone is. That's really doesn't fly today, because there's so many ways in which you can overcome that and have a restoratively driven placement. Okay, so the next thing you need is apical native bone, because you've got to secure both the bone ring and the implant and have good initial stability, 0 micro movement. And 2, you have to be far enough away from the adjacent teeth, because the last thing you want to do is you want to nick the teeth with the trephine. In those scenarios, basically, you're going to want to do those in a 2-stage approach as well. And obviously, distance from relative anatomy. You don't want to be placing your implants to secure it apically into the mandibular nerve or mental foramen, or even into the floor of the sinus. So essentially, in your decision tree, you have 3 choices. One, the first choice is a 2-stage approach, either extraction or ridge augmentation in one procedure and then going back at a later date and placing your implants. Second option is a one stage. That means you either extract or GPR or ridge augmentation with or without a simultaneous GPR procedure. Last option is a one stage approach with your extraction implant using an allograft ring. Using an allograft ring. So basically, you have three choices. First, we talked about the Bennett Hammerly ridge defect classification. Obviously, 0, 1, 2, 3, 4, and 5 are 0, 1, and 2 type defects. Well, those are immediate placements, no doubt about it, with or without a simultaneous GPR procedure. Class 3, 4, and 5 type defects, if it's outside of the bony envelope or you cannot be placing these implants in a restoratively driven position, those are cases that you're going to want to do it as a two-stage approach. Now, if you can place your implant within the bony envelope and in a restoratively driven fashion, those are the cases that you're going to be using the allograft ring. Okay. Now, taking this one step further. Now, if you have a situation where you really don't have room to place even a 6 millimeter diameter allograft ring, okay, the defect is so large, or you're that close to the adjacent teeth, you're going to want to do this as a two-stage procedure as well. Okay. However, if you have a situation, a scenario where you have greater than a millimeter or a millimeter and a half or so from the adjacent teeth, take this very large extraction socket, those are situations where I would strongly recommend using an allograft ring. So here we're looking at the upper left tooth number 12, badly broken down, large extraction socket. Typically, I'm doing this procedure as a two-stager. Okay, but now with the allograft ring, I've got a situation where I can actually do it predictably. But most importantly, I can place this implant and GBR and actually place it in a better position than where we started. If you take a close look, you can see how close we were, the angulation of the root of the upper first bicuspid with respect to the second bicuspid. So here, I placed my ring. I used this case. I actually didn't use a xenograft. I used a particulate allograft, collagen membrane on top of it. Okay, this is some initial healing. Sometimes you do get a little bit of cover screw exposure, but actually that obviously did not pose any problem at all. Here's our stage 2. And this is what, if you look real closely, I've got really nice placement of my dental implant with respect to the adjacent teeth. Okay, and that's another advantage that the allograft ring affords us. Okay, so the next thing we want to look at is less than 3 millimeters of apical native bone. Well, situations like this, if you take a look at this case, here we have a scenario where the upper second bicuspid, left bicuspid, number 13, badly broken down, unfavorable root fracture, but we're right at the floor of the sinus. So this is a case that I'm still going to do as a two-stage procedure using a particulate allograft and then ultimately placing my dental implants. Okay. Now, if I have greater than 3 millimeters of apical native bone, well, those are scenarios that I truly believe that the allograft ring is very, very, very predictable. Now, this is kind of a fun case. You may or may not have seen this case in the past. Some of the participants did, some of them didn't. But here we had a situation where we had a 4-unit bridge that clearly the peer abutment, the second bicuspid, I think most of us can recognize that that's a fairly good root fracture. The cuspid actually has some significant amount of recurrent decay. So prior to the case getting to me, they did some root canal therapy on number 11. And then my restorative dentist actually provisionalized it for me. I took out number 13, and you can see a pretty significant bony defect here. pretty significant bony defect. And I said to myself, this looks like an allograft ring to me. But I had to make sure that we had plenty of apical native bone to secure our dental implant. So here we went ahead, took a CBCT right at the time of the surgery, and I saw I had about 10.5 millimeters of bone, plenty of room for me to place our implant. Okay, ended up, this is our allograft ring with the implant already secured. We had plenty of, like I said, apical native bone. Great indication for the allograft ring and simultaneous implant placement. An occlusal view. This case I used also a Xenograft with a Straumann membrane flex. This is at the time of healing. You can see we got an ISQ value of about 68, which again is a very, very good ISQ value considering that it's 90% bone graft. Here's our radiograph at the time of installation of delivering the restorations, and you can see a really, really nice osseointegrated implant in the second bicuspid area. But this is what makes me really happy. Okay, we have complete restitution of our buccal plate. And that to me is huge. That gives me an awful lot of confidence in these procedures that if it's, again, a predictable use for it, for the allograft ring, that we're going to be successful. Here's where we started. Here's where we finished. And again, a very, very predictable use for our allograft ring. Now, this is always the toughest part, talking about complications. Okay, and there's a lot of reasons for complications with any technique for that matter, but most of it comes from, I think, trying to push the envelope a little bit too far. I'm going to show you a couple of cases and how I believe that it can be overcome really, really nicely. Here's a scenario where we have extracted an upper left cuspid. You can see we have a big, big, big time dehiscence lesion, large extraction socket. In my mind, a very, very good indication for the allograft ring. Here's the ring in position with the implant. You can see our positioning of the dental implant. You can see that we're obviously it's in a restoratively driven fashion, restoratively driven position. Here's the cover screw on top of the implant. You can see we used a particulate graft on top of it. But this is, I don't know if you can see my cursor, but here's where the problem is. We have no attached tissue. Okay, I hiked up that mucosa high, really, really high, and there's what I consider too much tension on this flap. It really isn't a passive closure. And that's one of the things that Dr. Giesenhagen always, always recommends is a passive closure. So here's where the allograft ring is. Here's where the bone is. Here's what it looks like immediately after the surgery. And this is a 1 week post-op. I'm looking at this and I'm going, oh my goodness. In other words, I defied a lot of the things that I preach. Okay. And when I think back on it, it's one of these things when I became a little bit too comfortable and thinking that, I've had an awful lot of success doing this, that I can start trying to push the envelope. And that's your biggest mistake. Okay. So I allowed this to heal a little bit longer. Clearly, we have some necrosis of our flap, exposure of the membrane. And then we just went ahead, let it heal a little bit longer. Ultimately, it healed itself over. But this is what I want to show you. Okay, opened it up. Yes, we were very fortunate. We've got a nice buccal plate here. But if you look at the radiographs, we lost a significant amount of bone on the distal aspect of the lateral incisor. An awful lot of bone on that lateral incisor. And clearly that's not something that I wanted to happen. Okay, and that's because I think because of my incomplete closure or a lack of really of paying close attention in terms of closure. I'm going to show you another case that I did. This is along the same lines, and I really do believe that most of our complications come from a lack of adequate of our closing of our wounds. And here's the situation. We had a large extraction socket, placed my allograft ring. Here's the implant in position. That's what it looks like from an occlusal aspect. Relatively good implant placement. And this is how we went about it. I used a Xenograft on top of it. I used a collagen membrane. Did not necessarily tack it down in this situation, but here's where we went south. I decided that I was going to see if I can have soft tissue kind of grow over it. Is it possible? Because I've done it in the past with conventional GBR procedures or socket regeneration type procedures. Maybe I can do it with this. You know, it's one of those things where I started trying to push the envelope and see how I can put my own slant on this procedure. Well, clearly, this is the exact wrong thing to do. Okay, here's where we came here's where things started going sideways, and you can see that this soft tissue, we had incomplete healing. Yes, the soft tissue is growing over it, but clearly this is not what you want to see happening. And here's at the time of 6 months, we lost a considerable amount of threads around this implant. And it was something where I decided I treated almost as like a peri-implantitis case. I thoroughly debrided the area, grafted it, used collagen membrane, closed over, but the soft tissue wasn't all that great, and it didn't have complete closure. But fortunately for us, it did heal over very nicely. And then ultimately, this is the final restoration, and this is where we wound up. We were able to regenerate some of the interproximal bone between the bicuspid implant and the molar, but clearly, again, I would not ever recommend not getting complete 100% closure prior to sending the patient out of the office. Now, I'm going to show you what I consider a far better approach. What I did here, this is a patient who was referred to me post Invisalign. As a matter of fact, you can see some of the buttons from this Invisalign treatment. But I think most of us would agree that this Invisalign case went a little bit sideways when you see the CT scan. The practitioner actually moved the tooth way outside of the bony envelope, and this tooth had about a class 3 mobility. You could take it out with your fingers. That's how loose this tooth was. So what I decided to do here, because I do ultimately learn my lesson, is that what I did was I took the tooth out, I extracted the tooth, and let it heal. I allowed it to heal for 6 weeks to hopefully regenerate some of this soft tissue. So when it came time to placing my dental implant, okay, I had plenty of soft tissue, and that's sort of the name of the game, attached soft tissue, keratinized soft tissue. Here we went in to place our implant. You can see I just went in with my Trefine. I typically like to use some of these bone chips, particularly when I'm taking away a lot of bone. I don't like to sort of waste it, if you will. Flatten the floor with the planator. Here's my ring in position, very, very secure ring at this point. Secured it also apically with this is also a 6 millimeter diameter bone ring with a narrow connection bone level tapered implant. And then on top of it, I used the Xenograft. This is a collagen membrane, closed over, allowed it to heal. And if you see the before and after, you can see a considerable amount of new keratinized soft tissue, which again, I love to see. I think this is the only way to handle these types of cases. Open the area up, Okay, that's your panoramic. Open the area up, and you can see again what with the CBCT a nice thick buccal plate, which to me is, it just makes you feel really good that you're going to have a very very good implant, nicely osseointegrated integrated implant at this point, nice thick buccal plate. This is the stage two, and this is a very, 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 very mediocre restoration done by a fast food dental chain type of office, and that didn't work out very well. But the truth is that we've got a very nice osseointegrated implant here, and I don't think that's going very anywhere at all. And the beauty of it is the patient is happy. And I guess at the end of the day, that's what really counts. Now, what I want to do is I want to move into a discussion about practice management. I think most of you who've come to um, my my course, I talk about the concept of being a GBRologist. And what do I mean by that? That means that the average case getting, again, in my practice, the average case getting referred is not the case with the straightforward cases where you've got yards and yards and yards of bone. Okay, I'm getting the cases that require guided bone regeneration to place it properly. And I really believe that as time moves onward, okay, I think it's going to be incumbent upon all surgeons placing dental implants that they're going to have to be proficient at guided bone regeneration, because I truly believe that the implants, especially with today's graduates, they all want to place implants, and they're not going to be that proficient at GBR. So those are the cases that they're going to refer out. So I really believe that it's something that each one of us should take to heart and get really good at these GBR procedures and also promoting them. So when I first started doing the allograft ring, I sent out this little newsletter. I put it together with one of the first two, three, four cases that I have done, sent it out to just about everybody and their mothers in dentistry in the areas where I practice. Okay, it got the word out. Okay, and again, when you start talking about the fact that you can do these procedures, do the GBR, and place the implant simultaneously, that it's a huge bonus for their patients. So that kind of gets things going. Now, for those people who aren't, other things that I'm doing now is I'm doing not as elaborate of these newsletters, but what I do is I put together these PDFs, if you will. And it's just about 10, 12, 15, 16 pictures in a PDF form. And I just send them out to the dentists in the community, successful cases. I just send them right out. I inevitably two, three, four. If you send out 50 of them, you're going to get two, three, four people actually give you a call and ask you a little bit about them. And so that's how I market to the dental community. Now, for those of you who are not photographing your work, there's a number of different ways in which you can get the word out. And Straumann has been good enough to get a couple of articles out into the compendium. This is one of the first ones I put out back in 2017. Myself, Randy Korn, my partner, and my son Ross put together this article that appeared in the 2017 issue. And then recently we put another one together that's in the June 2019. And I'm sure you can get PDFs of these articles or to send out to your referring doctors or reprints or something like that and get it out to your community. And again, to be honest, I get it. A lot of people aren't photographing their work as much as OCD people like me are. But the truth is that that's a good way of getting the word out also. Okay. If you do photograph your work, I mean, I do a lot of these. I do a lot of study clubs. I've done a number for myself. I've done a number for other allograft ring users, and trying to get the word out and showing their referral base how effective this can be for their patients. Another article that's coming out that I did also with my partner Randy and my son Ross is going to be in the International Journal of Periodontics and Restorative Dentistry. It's coming, it's already accepted for publication. It's going to be out in 2020. And this is a very, very inclusive, uh, really sort of comprehensive article that's going to be in that journal. And again, I'm sure you'll be able to get reprints of it, or if you're, that'll be coming hopefully out in June of 2020. And again, it's a good way of getting the word out to your referral base. Other ways in which I'm doing it, every single time I do one of these procedures, I try to take at least one or two pictures, include them in my post-op surgical letters, and I include them in the surgical completion report. And I think that's another very, very good way of doing it. That's external referral is throwing a blanket out to the community. Internal referral is through patients. And again, as I said earlier, once a patient hears that I can do this procedure in one surgery, and even in sinuses, it even cuts down on total treatment time. It cuts it down from 9 months. If you're doing a two-stage, you usually let your grafts heal for 6 months and then place your implants, which tacks on another 3 months. You can do it simultaneously, cutting down overall treatment time by a solid 3 months. And I firmly, firmly believe that it differentiates your practice. It makes you appear up to date, latest and greatest. And I truly believe that once patients see that, they feel very comfortable. The doctors in your community, your referral place, will also appreciate the wow factor. So benefits: one-stage procedure, clearly less surgery, and also extremely cost-effective for the surgeon. I think that the more you can complete in one sitting, the better off you are. So essentially, that's where I'm at right today, okay, with the AlloGraft Ring procedure. I still have a lot of confidence in it, and I still believe that there's still a number of people who are not using the AlloGraft Ring to its full potential. And at this point here, I welcome any questions, and I thank you for your attention, and feel free to contact me. That's my email address at the bottom there. Feel free to contact me if you have if you want to share cases with me. I'd be happy to hear from you guys. Okay? So with that being said, Victoria, I think I did pretty well here at 47 minutes and 30 seconds.
I was just going to comment, you are very punctual, so I appreciate it. So thank you so much. As Dr. Miller said, we're now opening up questions. So if you look at the control panel on the right, you will see a little box for questions, so you can type in your questions. So we did get one question already, and the
Mm-hmm.
question is, any tips on aligning the 2.0 drill with the center of the bone removal burr for the ring?
Let me see if I understand that. Is there any tips for well,
Aligning the 2.0 drill with the center of the bone removal burr for the ring?
the bone removal? I assume the bone removal burr for the ring is the trefine. I'm pretty sure that's what it means. Well, the truth is, okay, I think I understand the question. So when your first twist drill is a 2.2 millimeter twist drill. Okay, and that sometimes in these deep extraction sockets, the guide pin for the trefine is not long enough. Okay, so I actually noticed that the first time I took the course. And what I did was I decided that it was going to be my mission to help sort of figure out a new way of doing this. And what I thought to myself is having either a retractable guide pin, okay, that could fit into that 2.2 millimeter twist drill, into the 2.2 millimeter guide pin that would fit into the trefine that would engage your twist drill preparation, your original twist drill preparation. Well, I thought that that was a brilliant idea. And like most brilliant ideas, there's usually someone else who dreams of it first. So when I talked to Natalie about this about 3 years ago, 2.5 years ago, it turns out that this guy owns there's some guy who owns the patent to this concept. And he's willing to share that with us, but it would make the Terfines incomprehensibly expensive. Okay. So we're trying to come up with a new design that would make it retractable. So the actual guide pin in the Trefine, which is very short right now, okay, which is extremely short, would engage that 2.2 millimeter twist osteotomy. And that is in the planning stages. And that I can tell you would be a huge bonus. But it honestly, it hasn't been as big of an issue as I really thought it would be initially. Then I'm being really quite honest because the next two drills that you go in with, you can redirect things. The 2.2, 2.8, and the 3.5, you can redirect things. Okay, and generally speaking, it hasn't been as big as a problem as I thought it was going to be. I hope that answers your question.
Thank you. The next question. I've seen that allograft ring cases are done guided. Have you ever used guided ring placement?
Yeah, I was actually yes, I have, but it's really not guided. It's partially guided, and the reason being is well, actually, for a number of different reasons, it's almost virtually impossible because if you're using a 6 or a 7 millimeter ring, particularly a 7, that means you have to have at least an 8 millimeter sleeve, and that gets awfully wide. And the truth is that we I believe it's partially guided, and I was actually considering whether to show some of my guided cases. But the answer is yes, I do it guided, but I call it partially guided. I don't call it fully guided. The answer is yes.
Great. Next question. Do you always use xenografts whenever placing your bone rings?
Ah, that's a great question. I applaud the person for asking that. Um, the 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 truth of the matter is I use both. All right, and two things come into play. When I have a situation where I'm really looking for almost like a contour graft or a situation where I'm concerned that I'm not going that I almost want to make sure that I have a thick enough buccal plate, I'll use Xenograft. If the implant is purely within the bony envelope, okay, 100% within the bony envelope, and basically I'm not looking for a contour graft, I will use allograft. Okay. Sometimes I use both. I think one of the cases that I showed, I actually use both. Actually, the first case, I used both allo and xeno. I used the allograft because, yes, the implant was within the bony envelope. Okay. And basically, I was just kind of repairing that dehiscence lesion. And then, so I used allo on top of that, mixed with emdogain. And then I use the contour graft of well, today I'm using Cerebone, but that one was that was Straumann Xenograft. But the truth is that when I'm looking for the contour graft or a much thicker buccal plate, um, I will use a xenograft. So I use both. Now I've got to be honest with you. When I had the allograft ring forum going, I used to get beat up by a lot of the Europeans because they only use xenograft in Europe, and so their protocol calls for xenograft only. Dr. Giesenhagen is a little more open-minded about it, but not all of the Europeans are. So that's actually a very good question. And typically, whenever I'm in contact with some of these Europeans, they love to take pot shots at me. So I hope that answers your question as well.
The next question is, I have trouble removing the patient's bone with the planator in a few cases. Do you have
Hmm.
any tips?
Yes, replace your planator. It depends how many. Like I've replaced my instruments probably 4 times at least. They do get, and it's particularly if you're using, if you do 1, 2, 3, 4 times in very dense cortical bone, they dull out pretty quickly. So the
Great.
answer is you probably need to consider um, that you probably need to consider using uh, new instruments. Now, one of the times, and what I did was I went in and I actually removed some of it with a handpiece, a high-speed handpiece. I've done that also when my planator was a little bit worn down. Right, but when I recognized that it was becoming dull, I went in with a handpiece and I removed some of the bone chips. Okay,
Great.
so go in, remove as much bone chips as you possibly can with hand instruments, and then you can start using a handpiece, and then you can finish it off. Usually, when you're that far deep, most of the bone is more cancellous in nature, and it's a little bit easier to, even with a dull planator. But clearly, the answer is replacing your instruments.
The next question is, what insurance codes do you use for
Oh.
the bone ring ridge augmentation and for the sinus lift?
I'll tell you what, whoever said that question, please email me. You are talking to the wrong person, okay, with that. And I will defer that to my office manager because I don't even know what the code is for initial examination. Okay, I apologize for that, but I have people who do know that. So email me at drmiller@webperio.com. It should be up on your screen right now. Email me and I'll be happy to get you that information. I'm so sorry. I don't have that at my fingertips.
All good. All right. The next question. I did not notice pins or screws in the radiographs. Are you not
Hmm.
fixing the membrane?
Most of the time not. And when I do fix it, I fix it with the fixation cap. I use a fixation cap. A lot of the times, in the older cases, I was actually suturing my membranes. Okay, that's another trick. Very rarely am I very rarely am I tacking them. I probably to date maybe only 1 or 2% of my cases that I actually tacked, and I don't find a particular advantage to it. So I've been suturing my membranes, which I've been doing for a long time. And or if I could, I've also used my fixation caps to secure it too. I think that works out just fine for me.
Great. Next question. Do you use this technique in total edentulous cases? If yes, how soon can the patient use the prosthesis?
Mm. Deciding whether I should answer this question. Um, the truth of the matter is I have one case where I immediately loaded. Okay, but it's with 5 other implants. Okay, so the answer to your question is it depending on on how stable it is, and I've been able to get things fairly stable. Now, honestly, I'm not recommending that to the novice user or the person who's only done, 5, 6 of them so far. I wouldn't recommend that. The bottom line is you can, if it's in concert with other implants. In other words, if you're getting cross arch stabilization, a lack of micro movement, because that would all be the kiss of death. Okay, for your implants. So I have immediately loaded one. Now I'm not going to promote that to people who've only done that a couple of different times. I have a friend of mine, Daryl, out in California. He's done it before as well. So there are people who can do it, but these are people who've done a lot of them. Okay, and the truth is it all depends on your initial stability. In terms of actually loading these cases, I still have no problem asking my patients to wait a full 6 months. I really don't. And I think that I find pushing the envelope is when I wind up with adverse events. And if you follow the protocol, get comfortable with the protocol, and don't, I guess, cross certain lines. I think that's the best way of saying of approaching it. You will be far more successful. Okay, it's when you start crossing lines that things become that things start to go sideways. So the truth is that it's like just about anything else. I mean, a lot of us have done GBR around certain implants that we're immediately loading. If you're doing a lot of these amount of immediate load, immediate provisionalization cases, and you're very comfortable with it, okay, the same parameters fall into play. So I would suggest, um, again, if you've only done a couple of them, I wouldn't suggest that being your first. But if you're comfortable, have a lot of success under your belt, and I've been in touch with a number of different people who've done an amazing job with some of these cases, and they can start, I think, will start moving in certain directions like that.
Great. And the last question. Nice presentation. Can you use a cytoplast over the top of a bone ring instead of advancing the flap for primary closure, or is this pushing the envelope?
I think it's pushing the envelope, and I think you really want to have soft tissue on top of it. I don't know anybody who's ever used the cytoplast membrane on top of the bone ring yet. Um, I, uh, I would strongly advise not doing that, not leaving it open, because it's all about a tension-free closure, and it's also about nourishing the flap also occlusally as well, not just buccally and lingually. I think that's where those two complications kind of came into play, because I don't think they were adequately the bone ring and the bone and the I don't think it was adequately nourished, and I think you definitely need to cover the everything completely. I don't think I can tell you right now I will never not close it primarily. Okay. Now, I also know people who've actually put healing abutments in place. Okay, that's a different story. But I know people who've done it that way, and I've seen success with that. But I personally haven't done that. I just am. I just don't want to introduce something that may or may not work 100% of the time. But if you follow the protocol and understand the biology, okay, that you do need to nourish that your bone, you'll find yourself with less adverse events.
Excellent. So that concludes all of the questions. If anyone has any more questions, please either type them in now or you can
Hmm.
email Dr. Miller directly following this webinar. But if that is it, I would like to thank Dr. Miller so much for taking time out of his evening to do this webinar, and thank you all for attending. It was recorded, so once we get approval from our regulatory department, we will disseminate the recorded webinar to you so you can rewatch it over and over and over again.
Oh, I'm starting to get emails already.
Oh, that's great. Excellent. And Dr. Miller, did you have any final thoughts or anything else you wanted to say before we end the webinar?
No, I want to thank everybody for for participating. I want to thank you, Victoria, for putting this all together, masterminding this, and encouraging me to do this. I think this is, like I said, I do believe it was long overdue. And I want to emphasize the fact that I feel comfortable, um, asking me questions or whatever. Feel free to email me, and I will get back to you pronto. Okay. And I thank you, everybody, also for bringing me and spending the evening with me. So, with that being said, have a good evening, and I will hopefully see you guys soon.
Thanks so much. Good night, everyone.
Bye bye now.